Here we are, Alan, on a Sunday morning, and we're going to talk about the new American Heart Association blood pressure guidelines. And I thought it was important to talk about for a few reasons. One is everyone else is talking about it. It's been sanctified, if you didn't know, as legitimate and has the authoritative power by CNN and MSNBC and even Fox. They all have said, it is. And
Important medical institutions.
Yeah, it's very important, but they're the ones who even most doctors listen to if you want to read about how doctors get their
Well,
information.
why would you want your doctors to read scholarly articles, when you could get it on CNN?
A funny side story that my mail went to the wrong house. It went to my neighbor's house. And she called me up and she said, I have some things in here. I have the Journal of the American Medical Association, New England Journal, and Cleveland Clinic, and People magazine. I said, well, throw out the other three, bring me over the people. He said, I said, I need to know what's going on in the world. So I want the truth. Yeah, doctors, that's a whole nother topic of where doctors get information. But yes, the media is their number one source of information and headlines.
Yeah,
Headlines,
absolutely.
not reading anything more than a headline. But and guidelines. So doctors are very influenced by guidelines. And the questions this guideline brings up so many questions. First of all, American Heart Association, what's their authority? What's their financing source? Who are the people on there, these experts, these alleged experts who are able to tell us what blood pressure should be? Where'd they get their information? What studies did they use? And the most disturbing thing about this particular set of guidelines is they're not age specific. And as someone who is a geriatric doctor, if I followed these guidelines, my patients would be face planted, confused, delirious, not interested in living anymore, and everyone will be happy because their numbers are good. And the guidelines go against guidelines from groups like ours, the American College of Physicians, American Society of Family Doctors, or whatever it's called, Society Association. But anyway, yeah, that's what I thought we should just say something about these
Yeah.
guidelines.
So, we know a few things, Andy. The first thing we know is most guidelines are handpicked experts of who determines, who is the expert in the field of hypertension. Um, And then they're part of a society like the American Heart Association and the American College of Cardiology, which I guess co-brands these guidelines. And when you look at, many of the folks on there, if you put their name into ProPublica, you're going to see, and ProPublica for the folks online is for what's called the Sunshine Act. So if a doctor receives payment from an insurance company for speaking and travel, it goes online and you could see how much money is made by that provider. So that's
By,
one
by,
thing.
by insurance and pharmaceutical company, right? I mean,
Exactly.
yeah.
But it doesn't always include all the payments. There are certain like consulting fees which are considered actually legitimate that are excluded. So everything is not included in there. But I recently gave a talk, and on there I saw in the research that we did, and it's a bit in the book, that something like you know 2,500 doctors get about a $500,000 a year from pharma, and about 700 get $1 million a year. And many of these are the experts who are making the guidelines. We know that the American Heart Association is greatly funded by pharma, and it's in their interest for us to write more drugs and many drugs. And we know that the American College of Cardiology is stuck on a number-driven system where people are looking at one organ and not when you treat that one organ. And I guess maybe you could say this organ is the brain and the heart because, lowering blood pressure prevents heart attacks and strokes. And they ignore the fact of what happens to the rest of the organs, like the brain, when, someone gets too much blood pressure medicine and they syncopize and injure themselves.
Yeah, yes, and the experts have been shown over and over again to be drug company people. Even those that don't get direct money are doing studies funded by drug companies, so and they could claim they don't get any money. That money goes to the institution that they work for, Harvard. Harvard pays them. Everyone's happy. They have to produce a study that the drug company wants, or they're not getting the next study. So they're equally pawns, and they could have plausible deniability about getting the money. But when you look at experts, that's what they are. They're not actually good at anything necessarily other than working for drug companies, and they certainly have no clinical experience like we do, seeing the ramifications of these things. Yeah, heart association is basically an organ of the drug companies, and it's amazing it still has any authority at all. But yeah, it's the idea of this study. So the guidelines are basically blood pressure under 120 is normal. 120 to 130, stage one, 130 to 140, stage two. Um, Need to treat those numbers. Our organizations, based on robust research, by the way, we talk a lot about this, what we call the blood pressure epidemic. We talk a lot about this in our book and give all the studies that they're using. Our organizations have a number of 150. That's where blood pressure starts at 150. So you can see the dramatic difference. And our organizations do not get on TV because these TV channels are also sponsored by pharmaceutical companies. It's a horrible situation. So one study, the Sprint study, which we dissect in our book, because it's a horrible study of people who have severe heart disease, and when they gave them extra blood pressure medicines and got their blood pressure under 120, it was like a 50% reduction in death and hospitalization. And we show that that translates to about 1 in 1,000 people. And we don't know if it's from dropping the blood pressure or because this added medicine helps their heart disease. They don't distinguish. In addition, you mentioned strokes, especially in old people. If you drop the blood pressure too far, you cause strokes because you don't get any blood to the brain. So in this study, what they don't talk about is the massive increase in kidney disease, in hospitalization, in stroke-like symptoms. And we have a recent study showing, and by the way, in this study, if your blood pressure was over 180, it was considered a medical emergency. Alan, my patients who are old, their blood pressure when they don't have a bowel movement in the morning and they're stressed goes up above 180. I
Yeah.
mean, it
So,
just happens all the time.
uh,
So there's a study showing if you treat those people with spikes in blood pressure, this is a study we mentioned in our book, that you actually increase stroke, you increase kidney failure, and you increase death. And this study was stopped early because of the dramatic increase in bad outcomes by treating the very blood pressures that this new guideline says must be treated emergently in a hospital.
yes, I got a call from my NP yesterday. This one's hot off the press of like a 78-year-old man who came into the office yesterday for follow-up, and he decided to stop his blood pressure medications. And his blood pressure was 190 over 120. And she did the appropriate thing. She did an EKG. There was no changes. She dipped his urine. There was no protein or blood in the urine. He wasn't bleeding anywhere. And he had zero symptoms. And she wanted to send him to the ER. And I'm like, Jane, the guy stopped his medicine for 2 months. You're going to send someone to the emergency room for a number. He doesn't have a headache. He doesn't have chest pain. Have him restart his blood pressure medicine and
Right.
recheck it. But this is the reflex out there. We treat numbers, not people. And that's just another example. But there's a couple of things, from my reading, because I have to be honest, I didn't dive that deep into it until recently, because I didn't quite get the nuances of some of the changes. But the nuances of some of the changes are significant. To me, one of the biggest ones is they essentially say, you know, keep getting the blood pressure lower. Like that the ideal blood pressure is as low as you could get it. And and
Right.
and I found that truly unremarkable. Like, what is the end point? Is the end point killing somebody? And now we've got a very low blood pressure.
Yeah, we passed the guideline. I mean, that would be actually a positive result for these things. And yeah, the idea that lower is better. So two things. One is we've now added hundreds of thousands of people into the realm of being sick. Now they have a disease now that they didn't have before because we've lowered this threshold of blood pressure so low. And these people now have to see doctors and get tests and do things to fix their number. Secondly, because there's no low endpoint, we could kill people and pass the guidelines. That would be perfectly fine with the American College of American Heart Association. But third is the idea that there's no science behind any of this. That this one study we mentioned, the Sprint study, has been contradicted by dozens of other studies that show dropping the blood pressure in elderly people, especially elderly people with kidney disease or cerebral vascular disease, they've had strokes, dropping it below 120 increases death, increases mortality. And we know as doctors, which of course they don't ask these questions in the studies, we know what it does to people. We know it makes them dizzy, it makes them tired, it makes their brains not work very well. They can pass out. These are not endpoints they look at the study because they're called soft endpoints, Alan. They're subjective. You can't measure them, so they don't exist. That's part of the problem with the Flexner system. Unless you can measure it, it doesn't exist. But it would destroy my patients to have this kind of blood pressure.
Exactly. And, in our talk a couple of weeks ago, we talked about what's becoming the number one cause of death in the elderly in our country, and it's falls, and it's from many reasons, but, over medication and polypharmacy. Most of those people are on seven, eight, or nine drugs. And that gets to the other point that really startled me, which I don't see how you could say, in my opinion, how that's good medicine to start two blood pressure medications at one time. Like, why would you want to do that? Like, I always learned in my career, you start with one drug, you go low, you go slow, so you don't develop side effects, you don't develop kidney problems, you don't develop falls, and you get the patient to a comfortable blood pressure that is safe for that individual, not for the number.
Yeah, we've kind of been duped into thinking that high blood pressure is a medical emergency. And if you look historically at people with high blood pressure over our before we became such a technological medical society, I mean, it takes years for high blood pressure to start causing damage. It doesn't cause damage today. Like when your nurse practitioner wanted to send this patient to the ER, the chance of getting hurt from the ER is far higher than the chance of getting hurt from a high blood pressure. Yes, we should bring it down, but we have time. Having said that, low blood pressure will cause damage immediately. So once that blood pressure drops, you are depriving your organs of oxygen immediately. So, I mean, this idea that we should be using two medicines, treat aggressively, is just goes against every bit of medical literature and experience that we have, and it's going to hurt people. But once again, Alan, hurting people is good for the medical industrial
Yeah.
complex.
And we created this emergency even more by creating another new number of lowering, numbers for chronic kidney disease. So now you have even more of an emergency because, your 85-year-old's creatinine is starting to bump up a lot, and he's now got CKD3, and he might die in 6 months if you don't put him on four blood pressure medications.
Yeah, and I got to tell you, I made a little calculation, and 90% of my patients have either stage 3 or 4 kidney disease, which I call normal. So when I send them their blood results back, I say your blood results are normal. And they write back and say, but I have stage 3 kidney disease. I said, yeah, that's normal. That used to be called normal, and it still is because these people don't go on to dialysis or to have any kidney problems. They basically are normal, but they've redefined that, plus these new blood pressure guidelines, plus the diabetes guidelines, which have also changed that you have to go lower and lower. So yeah, now people are on 12 medicines, see 3 specialists, and are falling. So then they see some more specialists and they're tired. So they see more specialists and get more medicines and more tests. And you can see the spiral that a guideline like this can cause, which basically is going to make people a lot sicker. And the American Heart Association will be thrilled by that result.
The other thing I noticed, I looked at which organizations did support this, and you're right, so my academy is the American Academy of Family Physicians, has not endorsed the guideline, but I did notice in shock that the American Geriatric Society did.
That is shocking. And they are also, unfortunately, a society that I've come not to trust. Having gone to several of their meetings, they're just rooms and rooms and rooms of drug reps. The drug reps, sponsor the entire conference and pay a ton of money to the society. And at this point, there's very few it's interesting. The society we belong to, the Lown Institute, and then the Right Care Alliance, died because it didn't take drug company money. We couldn't even afford a conference. So these people just dive deep into the drug company world, and it's no surprise they start endorsing things that they shouldn't. Geriatrics people should be ashamed of themselves for endorsing a study like this that is so antithetical to aging and to older people. I mean, it's almost shocking if we lowered the blood pressure to 120, what we would do to these people. I've seen the results of that, and it's something that guidelines need to be evaluated on an individual basis. They cannot be blind in terms of age. They can't be totally number focused. And if they are, which is all guidelines, we're in for a tough ride. And because who prevents this from happening, you and I do. Primary care doctors, and we're, like we've said, a dying species. So it's
Well,
going to be difficult.
a couple things there too. So now we're going to get ding more in our report cards because we're not going to
Yes.
follow the guidelines.
Right.
So
Yes.
now we're in trouble for doing what we think is right for, our elderly patients. That's one thing. And the other thing, which didn't surprise me after I thought about it, is the American Society of Physicians Assistants and the Nurse Practitioner Society are two societies that supported the guidelines,
Mm.
major academic medical folks. And I started chuckling and I said, it's a perfect example of how we treat these allied health professionals. They're designed to treat a number and to follow everything they do is behind a protocol. Like they have books of protocols on what you do if someone's got this, that, or the other thing. So it makes total sense because they're not reading any study, they're reading their protocols, which are also devised by pharma and specialty societies that in God they trust. It's just they trust everyone.
And once we become a protocol society like we're becoming, we might as well have robots just taking care of patients because the critically thinking doctor who views every patient as an individual, who listens to their symptoms, who's aware of how things affect them, that's disappearing in the world of protocols and guidelines. And having a computer there, a nice looking robot, I think,
So,
would
so
do
when
the
I'm
job.
teaching my residents, their phone is out, and one, they have the chart in their hand and the chart on the computer, so they could, double talk or whatever. And then the other thing they have is up to date. So up to
Yeah.
date to a resident is God.
Yeah.
And up to date, in my opinion, is not up to date. It's another set of quote guidelines that are made by paid physicians that are paid to do these chapters, and it's their expert opinion based on their own thoughts and research, and not necessarily the real up-to-date evidence.
Yeah, I mean the evidence itself is rarely looked at, and that's really a shame. And we to be critically thinking doctors, we have to be cognizant of who these experts are, what the real evidence is, and what our patients are telling us. Ultimately, listen to the patient, which is Osler's prime directive. Disappears in the world of guidelines because I think in our book, I talk about a story of a patient who started falling and getting confused, and their blood pressure numbers were great, and the son was like, "Yeah, well, I'm good with this," and people can get duped into believing this is a good thing, and
Yeah.
it's not
Yeah.
life saving.
And
It's not at all.
Osler said as well, if you have a patient with a problem, you have a problem. If you give him a medicine, now you got two problems. And if you give him three medicines and four, like you're just multiplying the
Yeah,
problems that you're creating instead of letting people age naturally.
yeah, and then that's hopefully these guidelines will be widely ignored as they are by me and you. Um,
So when I grew up, we were really taught, I don't know if you were taught the same thing, Andy, that normal blood pressure, the systolic, was 100 plus your age.
Yes,
That was
100
all.
plus your age. That was, and when I was in residency, a study came out called the SHEP study, which systolic hypertension in the elderly. which said that you know what, this isn't really true. It's 160 seems to be the threshold where above 160 people start having problems. And two things about Shep, which has never been disproven. 160 probably is the threshold, but over 160 consistently, like not spikes like we're treating now, consistently over 160, like you live at 180, not you had a bad day and you're at 180. And over that, it was a gradual increase in problems over 160 over a long period of time. So that was where it changed, but it changed in a what I consider a rational way. Now it's changing to an insane way that is patient harmful. And this is unfortunately the world we live in. This protocol world designed by drug company stooges, um, and who are held up as experts, is
So, Andy, my
what we're up
question
against.
for you,
Yes.
you have to think deep now. What is the answer to the problem we're in? It's really scary when you think about it.
I mean, the
How are we
answer
going to
is,
change this?
I mean, the answer is to have good primary care, like we've said all along, who actually are interested in patients and data rather than protocols. People like us, and there are other people like us around. So we're a dying species, but unless we revive vibrant, critical thinking primary care, yeah, like I said, we're in for the robot world in healthcare, and those robots are human beings who are just trained to be robots, which is just as dangerous. So yeah, it's hopefully if you're listening to this and your doctor is pushing a protocol, I would push back. You're in charge ultimately, and you don't want to lower your numbers too much, especially if you feel like garbage when it happens. Your body's telling you to back off. Okay, any last thoughts, Alan?
No, I think we've
That,
really covered it. It's just another example of the Flexnerian numerical system that we go on, and we've just lost